Welcome, everyone. We're just going to give a couple minutes for some people to trickle in. All right. Go ahead and get started. Welcome, everyone. I'm Rachel Atkinson. I am an MIS fellow at Brigham in Boston, and you're here tonight to learn some high-yield ABSITE review. And I'll introduce our presenters just in a moment here. This is hosted by the SSAT. This is part one of two high-yield topics for the ABSITE. And I'll have the date posted for the next one. That's in early January. This is me. Quick plug for the complex GI surgery fellowships. SSAT promotes these complex GI fellowships to train general surgeons to do advanced cases, at least 150 advanced cases in bariatrics, advanced MIS, HPB, flexible endoscopy, complex ventral hernia repair, and or colorectal surgery. And so this is to get you some extra reps with some complex cases at the end of your training. And I'll have a link to show you a link to the website where you can learn more. So SSAT, if you're a resident, which most people on the call should be, it's only nominal $20 annually for membership, and same thing for medical students as well. And being a member is really nice because you get benefits like being a free subscription to the Journal of GI Surgery. The annual meeting for SSAT is Digestive Disease Week. And if you're a member, you get a very steep discount on registration and a lot of access for things like research awards, travel grants, scholarships, as well as leadership opportunities, just like in other societies. It's a great way to sort of launch your career and meet other people with similar clinical and non-clinical interests by being on various societies, various like working groups within the society. The SSAT Residence Corner is actually amazing. So if you go to ssat.com/residence, there are some ABSITE quizzes that you can use to prep for the ABSITE. There's also the video library that has operative videos to learn different techniques from experts in the field. And then webinars like this one and others are always available on there on the website as well as on YouTube. So this will be available after for any review. So we can jump right in. Tonight, we are joined by three of my favorite old friends and colleagues who will be talking to us about these topics. So we'll first hear from Jeff Reeves, who is at UCSD. Sorry, my light just went off in the room that I'm in at UCSD. He'll be talking about esophagus, stomach, and GI hormones. Then we'll hear from Dr. Matt Eisperu at the Mayo Clinic, talking about thoracic trauma and critical care. And lastly, Dr. Elizabeth Yates at University of Wisconsin-Madison is going to talk to us about high-yield vascular. So, like I said, this will be recorded. You'll also get an email to remind you. You can subscribe to the YouTube channel so you get alerts. And the audio from this will also be made into a podcast so that if you are a on-the-go kind of person, you can listen to it like that. And like I mentioned, there will be a part two with completely different topics. So high yield from other topics we don't cover today, which will be on January 8th. So keep an eye out for the registration for that as well. And before we get started, I want to thank our panelists who will be giving us our review today, the Society, specifically the Resident and Fellow Education Committee. Dr. Fong, who I saw on the call, is our committee chair, and Dr. Narayan, who was the moderator last year and tapped me for this role. And of course, Bev Hendry, who is our stellar administrator. All right, I'm going to stop sharing and we will go ahead and get started with Jeff. There is a chat, sorry, Dr. Reeves. There is a chat box if you have questions during. I'll sort of keep an eye on it for anything that might be timely in the moment. Otherwise, we can save them for the end, but please do feel free to ask questions.
Okay. Good evening, everyone. Thanks for joining us. The good Dr. Atkinson here asked me to cover 2 organs in 20 minutes. So buckle up because we're going to roll through these pretty quickly. But this is recorded and you can go back and put me at half speed if you want. But if there's one thing to take away from tonight, it's that the stomach can be a forgiving organ, but don't mess with the goose. So the esophagus is a tube. It goes from your mouth to your stomach, takes food down there, and it starts at the upper esophageal sphincter, which is composed primarily of the cricopharyngeus. That's innervated by the recurrent laryngeal nerve that's commonly asked, and it's also the most common site for iatrogenic perforation. If any of you remember the first time you tried to do an upper endoscopy, you know why this is. It's pretty hard to get it through that first opening. Whereas non-iatrogenic, most common perforations are distally, usually left posterior lateral, just little tidbits. The esophagus can be thought of as segmental in many ways. There's no esophageal artery, but there are branches in different parts. And so in the cervical esophagus, it's fed by branches from the inferior thyroid artery, which is a branch of the subclavian. And in the chest, there are branches from the right bronchiole and directly from the aorta. And then distally, there's branches from the left gastric. They love to ask about surgical exposure. And so I remember that the esophagus politically leans a little left. So in the neck, you want to make a left neck incision, anterior sternocleidomastoid muscle. And in the chest, the aorta is in the way in the upper 2/3. So you have to do a right posterior lateral thoracotomy. But then distally, the aorta tucks back behind the esophagus and you can do left again. So left posterior lateral. And there is a couple centimeters intra-abdominal esophagus. So sometimes you have to do an upper midline to access that. So just remember left, right, left, march along, and you'll get those answers right. Speaking of left and right, there's the left and right vagus nerve. And as they come down the esophagus through the hiatus onto the stomach, they become the anterior and posterior vagus nerves, respectively. The mnemonic to remember this is LARP, but I just remember it because you put a laparoscope in the camera, you look in the left upper quadrant, you stare at the anterior stomach, so left anterior. They also have branches that you'll get asked about, specifically the hepatic branch, which comes off of the left vagus. This makes sense because the liver is anterior. The left lobe of the liver sits right on top of the stomach, and so it comes from the anterior vagus nerve, which is the left vagus nerve. Whereas the right vagus it runs posteriorly and gives off a branch to the celiac axis and trunk, and then those goes along the mesentery to innervate the gut. It also gives off this upper posterior fundal criminal nerve of Grassi, which is the one that if you miss it during a vagotomy, you have high ulcer recurrence. Speaking of vagotomies, often asked about, rarely done. There's 3 different types. And so there's the truncal, where you ligate the nerves just as they come, as the office comes out of the hiatus. Selective is where you do it after it gives off those hepatic and celiac branches. And then the highly selective or proximal is when you just cut the nerve endings and you leave the main vagus intact. This is important because that preserves the nerves to the crow's feet of the pylorus. And so you don't have to do a pyloroplasty, which for the other ones you do. Moving on to anatomy, highly vascular organ the stomach is. That's why it's so forgiving. But all of these branches come from the celiac. And so you have a left gastric that is one branch of the celiac, and a right gastric, which is a branch of the common hepatic artery, and those supply the lesser curve. Whereas the greater curve, there's the left gastroepiploic that is a branch of the splenic artery, and the right gastroepiploic, which is a branch of the GDA, and those supply the greater curve along with short gastrics. It's easy to remember this. If you remember that epiploic, it means part of the omentum, and so on the greater curve, there's the gastroepiploic arteries. Moving on to some pathology, paraesophageal hernias, there's 4 types, and they're defined by the relationship of the GE junction to the diaphragm. So in type 1, it's a sliding hiatal where the GE junction is above the diaphragm. Type 2, the GE junction remains in place, but the fundus herniates above that. next to the esophagus. And then type 3 is both. So G junction above and some herniated fundus. And finally, type 4 is where there's another organ besides the stomach. Usually colon, could be omentum, pancreas, duo. Type 1 is often asymptomatic, and when it is, you don't need to do anything for it. If there are symptoms, you work it up and manage it like GERD. Whereas type 2 through 4, sort of true paraesophageals, those in theory have a risk of incarceration. If they get larger, you can get volvulus. And so in general, on the ABSITE, you're going to want to repair a 2 through 4. Surgery for that is just a hernia repair with or without fundoplication. People debate that, so they shouldn't get you on the weeds there. They can be associated with Cameron's erosions, which are ulcers from the diaphragm pinching the stomach, and that leads to iron deficiency anemia. And so that, if a patient's anemic, is an indication for repair, and their anemia should improve. And they like to have one of these next step questions where they'll give you paraesophageal hernia repair and they say, what's next? You don't rush to the OR. You got to make sure you do an EGD beforehand so you're not surprised with a cancer or something else preoperatively. So always work them up with an EG and ideally a manometry if you can. If they're big enough, you can get gastric volvulus, and there's two types that can be confusing, but there's organoaxial, where the line is along the length of the organ, meaning the stomach, and then the stomach twists around that line. Whereas mesenterioaxial, the line goes along with the blood vessels or the mesentery, and then the stomach kind of flips. Organoaxial is more common and more dangerous. When you look at this picture, you can see how it's when it twists on itself, it's a little bit easier to get ischemic. And so if you see this on the ABSITE, you're definitely going to the OR. The operation would be to reduce the hernia, detorse the stomach, make sure it's viable. And if the patient is stable, then repair the hernia at the same time. If they're unstable, you can just do a gastropexy or use a G-tube to pexy the stomach in place so it doesn't retwist. If there's frank necrosis, you have to do a gastrectomy. Believe it or not, that is the right answer. If the stomach is necrotic, you have to get rid of it. Moving on to gastric ulcers, there's 5 different types of these. Number 1 is the most common, and it's the lesser of all of them, so it's on the lesser curve. That's how I remember it. And then type 2, 2 ulcers. 1 is anywhere in the body, and the second one is in the duodenum, 2 for 2. 3 for pre or pre-pyloric, where it's just before the pylorus. And then 4 opens the door at some high up on the gastric or the lesser curve. And then 5 is NSAID related. The question is always which ones are acid related, and that's 2 and 3 because they're in the middle, I guess. I don't know who made that up, but you can think of it because the body produces acid, and so that dumps onto the prepyloric space, and then it dumps into the duodenum, and that's why those ones are acid related. In reality, 85% of ulcers are H. pylori related, and the best way to diagnose that is with an endoscopy and a biopsy, a tissue biopsy. That's the gold standard diagnosis. Whereas once you treat it and you want to confirm eradication, the best test is a urea breath test. And that's because H. pylori produces urea. And so if you have it, you're still breathing it out. Whereas once you eradicate it, you shouldn't be breathing it out anymore. It also has antigens. And so you can do a stool antigen to confirm eradication. But that's different than the antibody, which will be positive for life. Treatment is with triple or quadruple therapy. There's different regimens, so you shouldn't, worry too much about memorizing it. But in general, it's a PPI, antibiotics, and bismuth. You only operate for complications for peptic ulcer disease. It used to be vagotomies was something that was standard done, but now you treat H. pylori, and that gets most of them. But if there's a perforation on the ABSITE, definitely go into the OR. You're going to do a gram patch, and it's important to remember to do a biopsy at that time to make sure it's not an underlying malignancy. If it leads to an obstruction, you can bypass that with a gastro-J. And if it's bleeding, you really want to try to not go to the OR. So GI once, GI twice, IR, and only if all that doesn't work, then you go to the OR, or if they're giving you an unstable patient. The way you fix these is if it's in the stomach, you do a gastrotomy. If it's in the duodenum, you open up a longitudinal duodenotomy to look at the bleeding vessels. Usually they're posterior because the mesentery comes from posterior, and then you oversew them. If you're in the OR for peptic ulcer disease and they're telling you that the patient is proven H. pylori eradicated and proven has been on a PPI for years, that's when you would consider doing an acid-reducing surgery like a vagotomy. That's also a scenario where you'd probably want to send a gastrin to rule out gastrinoma. Okay, esophageal dysmotility. Complicated topic, but the most common is achalasia. This is where you get degeneration of the inhibitory ganglion cells, so double negative degeneration of the inhibitory ganglion cells of the myenteric plexus, and that results in aperistalsis. So on the right here is a normal manometry where you have a nice move of esophageal squeeze. Aperistalsis looks like this, where it's all blue, no red, no squeeze. And then normally you're supposed to have relaxation of the lower esophageal sphincter, but in achalasia, there's no relaxation, and that gives you this stenosis here in the classic bird's beak finding. This leads to dysphagia with both solids and liquids, which is different than cancer, which typically liquids first, and as it progresses, turns to solid. But also, next step question, you have to do an EGD and get a biopsy because you need to rule out pseudoachalasia, where there is an occult malignancy that's making it look like achalasia. The treatment is complicated. There's medications, a lot of endoscopic ways to treat this, and I don't think they get too in the weeds because some of it's controversial. But if you end up doing a surgery, they may ask you about what that is, and that would be a halar myotomy, where you're going to do 6 centimeters of myotomy onto the esophagus, 2 centimeters onto the stomach, and you have to get through both muscle layers, the longitudinal outer and the circular inner layer. Usually a little bit of, you want to see the mucosa bow out, and then you put an anterior door fundoplication on top of that. Some less exciting esophageal dysmotility disorders that can confuse you is scleroderma. This is autoimmune. The smooth muscle is replaced by fibrous tissue. And so the muscle is gone. And so you also get air peristalsis because the esophagus can't squeeze. But instead of the lower esophageal sphincter being too tight, like it is in achalasia, it's actually too loose in scleroderma because their muscle's gone. And so this is important because you do a myotomy in achalasia, but in scleroderma, that's not going to do anything for you. So there's no surgery for scleroderma, just prokinetic agents. Then there's distal esophageal spasm or corkscrew esophagus. They call it that because it looks like this. And the buzzword is simultaneous multi-peaked contractions. Generally, it's not surgery first, just meds. But if you end up doing surgery, the key difference between achalasia is you got to do a long myotomy because the problem is all up and down the esophagus. So you basically incise the length of the esophagus. Lastly, there's nutcracker or hypercontractile peristalsis. And this is usually a single, very high amplitude contraction, so 8,000 compared to 120. The treatment is non-surgical for nutcracker, just calcium channel blockers. Okay, moving on to caustic injury, there's two types, acid and alkali. Acid causes coagulation necrosis. Alkali, which is drinking Drano, is worse, and that's liquefaction necrosis. I remember that because you can, have a bovie and accidentally coagulate something, and it's kind of a big deal. But if you liquefy something, that sounds really bad. So liquefaction is worse. When you see this, you have to do an endoscopy to assess the degree of injury to know how bad you're dealing with it. But importantly, do not put your scope past the site of injury because if it's severe, because you can lead to perforation. You try non-op management, which is admission to the ICU, resuscitation, antibiotics, NPO, TPN if you need, and surgery is reserved if you have full thickness necrosin or complications like perforation, sepsis, mediastinitis. If that happens, you have to go and resect all the dead tissue, do a spit fistula, leave some drains, think about feeding access. Along those lines is perforation. We already talked about the most common site is at the cricopharyngeus for after EGDs, right? For Boerhaave's, it's distal, left posterior lateral. You diagnose this with the gastrographin, water-soluble swallow. This is because if there's a hole and it goes through, the water-soluble contrast is more tolerated by tissues. And then the management on the ABSITE is generally going to be surgical. So if you're within 24 hours and there's minimal contamination, you're going to go to the OR for repair. Two-layer repair, leave some drains, think about a muscle buttress and feeding access. Whereas if it's been greater than 48 hours or there's extensive contamination, you can't repair that tissue because it's not healthy enough. And so you just debride, resect what's dead, and leave drains. The one question you might get is if it was for dilation during an EGD for achalasia. If you're in there in that scenario, you want to do a contralateral myotomy, meaning on the other side of the perforation, so that you treat the achalasia. Otherwise, you try to repair it and it won't heal. In practice, GI and stents can be helpful, but I wouldn't answer that on the ABSITE yet. I would just always go to the OR. Next, Barrett's esophagus. This is where you have that normal squamous cells, they change into columnar epithelial cells. The key word is goblet cells, and memorize this picture in the bottom right. Looks like a little glob of mucus. This is due to chronic acid exposure, and it has a significantly increased risk of adenocarcinoma once you have Barrett's. But just like colon polyps, there's always a progression from non-neoplastic metaplasia to low-grade dysplasia to high-grade dysplasia to adenocarcinoma, and it rarely skips steps. And so once you see this, you don't have to panic. The treatment is generally PPI, and that has a 75% reduction in the development of cancer, or send it to us and we get to do anti-reflux surgery. That's a treatment option. And then you have to screen it. Screening is with 4-quadrant biopsy at 1 to 2 centimeter intervals. That's a standard protocol reviewed by 2 pathologists. And if the biopsy shows metaplasia with no dysplasia, so metaplasia alone, it's safe to surveil these every 3 years. If there's low-grade dysplasia, you have to increase that frequency to 6 to 12 months, and you want to consider ablating it. If it's high-grade dysplasia, this needs to be treated, and that can be typically with ablation or endoscopic mucosal resection, EMR, and then you surveil every 3 months. But you can do an esophagectomy if they're giving you reasons for it. That would be large size, lymphovascular invasion. If they try to ablate it and it doesn't work, if they're pushing you towards surgery, you can do esophagectomy for this. After you have high-grade dysplasia, that's when things start to turn into cancer. And so let's talk about T stages. In the esophagus, you have the mucosa, then the submucosa, then the muscle layers, the muscularis propria, and finally the adventitia. And there's no cirrhosis in the esophagus. I remember this because it's in the mediastinum. It's surrounded by a lot of stuff, whereas other intestinal tubes in your abdomen are floating around in the breeze, and so they need a serosa. For T1 tumors, there's T1A and T1B. T1A is through the lamina propria but remains intramucosal, whereas T1B is submucosal. That's an important distinction because in submucosal are the lymphatic channels and it's a higher risk for spread. T2 is into the muscles, T3 is all the way through the adventitia, but T4 is when it invades into an adjacent organ. I remember the 1A and 1B difference. It's important clinically because when you do an endoscopic mucosal resection, what they do is they put the needle into the submucosa and they inject some saline to do a lift so that they can lop off the tumor. And that's only for 1A. For 1B, if that tumor is growing submucosally, you can't confirm that you can get it out. So let's talk more details about cancer. There's 2 types, squamous and adeno. Squamous, the risk factors are smoking and tobacco, and it tends to be, though it's not always the case, in the upper 2/3, and so lung mets are more common, whereas adeno is obesity and GERD related, thus more common in the US, and it's in the lower 1/3, and liver mets are more common. You always want to stage with an EUS, and that's going to tell you the T staging that we talked about in the last slide, and in general, a PET CT. If there's metastatic disease or nodal disease outside what you can resect with an esophagectomy, specifically if it's supraclavicular nodes, that's a contraindication for surgery, and you're going to do definitive chemo or radiation. If it's a T1A alone, like we talked about, you can do an EMR. A T1B, I would do surgery, which is esophagectomy on the ABSITE. There are some places that will do that, but I would answer surgery for T1Bs. T2 or greater, in general, you're also going to do neoadjuvant. Now, some places don't always do this. But I think, if it was me at this point in time on the ABSITE, T2 or greater, I would answer neoadjuvant. And definitely, if you see some positive nodes, they need neoadjuvant. The principles for esophagectomy are you want 6 to 8 centimeter margins, and you want to make sure to preserve the right gastroepiploic artery because that's the supply to the conduit. When you do this and you resect the esophagus and part of the stomach, you take the left gastric and you take the short gastrics. And so your remaining stomach, which is your new esophagus, is supplied just by the right gastroepiploic. If you ding that, you're going to get ischemia at the tip and a leak. Moving on to gastric cancer T staging. It's very similar to esophageal. T1A is the same, lamina propria, T1B, submucosal, T2, muscularis propria, that's all the same. The difference is T3 is subserosa because the stomach has a serosa and the esophagus doesn't. And T4A is through the serosa and T4B is adjacent organs. So you can go back and review those slides, but that's the difference there. There's also 2 types of gastric cancer, intestinal type and diffuse type. Intestinal type is generally due to environmental factors, happens to be in older patients, more common in men and more common in Japan. whereas diffuse type is familial, so it's in younger patients, more common in women, and it's more common in the US. Intestinal type, like the name implies, has a glandular type histology when you biopsy it, and it tends to be, like a single mass. Whereas diffuse type is poorly differentiated and infiltrative, has those signet ring cells, and so those are worse prognosis. And in general, you have to do a total gastrectomy for diffuse type, whereas for intestinal, you can attempt a subtotal depending on the extent. Just like esophageal, you got to stage with an EUS, and you generally add for gastric cancer a staging laparoscopy. Again, not every place does that, but if they give you that option, I think it's safe in the ABSITE to answer that because you can have positive peritoneal washings in up to 40% of cases. Neoadjuvant is increasing with stomach, but also not quite standard, so they probably won't ask you about it. The goals of surgery that you need to know is 5 centimeter margins and 16 lymph nodes. That's more lymph nodes than colon. Colon is 12, gastric is 16 for whatever reason. And then depending on where the tumor is the type of operation you can do. For distal tumors, you can do a subtotal because you have a gastric pouch. If you're doing proximal tumors, there's no pouch and you have to go straight to the esophagus. So that's why you need a total gastrectomy with an esophageal J if you're doing proximal. And then all of these should be done with a D2 lymphadenectomy, which is where you're taking nodes along the celiac axis. So all those blood vessels that supply the stomach, they all have lymph nodes, and those are lymph nodes that you take. It's that simple. D2 people make them complicated, but it's just the blood vessels that supply the stomach. Then let's finish with going over reconstruction. I'm almost done, Rach. There's Billwath 1, which is for one limb, where you just do a gastroduodenotomy. This is very rarely done because it's kind of hard to mobilize the duodenum to get a tension-free anastomosis here. Where D2 has two limbs, you're going to bring up a loop of jejunum past the LOT and do a gastrojejunostomy, and you have an afferent limb that goes to the anastomosis and an efferent limb that goes away. And then you'll see some texts and questions use afferent limb and biliopancreatic limb interchangeably because it's also bile and pancreas juice that is in that limb, whereas the efferent limb is called the alimentary limb because that's where the food goes. For Roux-en-Y, that's either for bariatric gastric bypass or if you're doing a gastrectomy for cancer, you're going to divide a loop of jejunum, bring that up, hook it to the stomach, and then make a jejunojejunostomy. And similarly, you have a biliopancreatic and an alimentary limb. So the ABSITE loves post-gastrectomy syndromes, and they love dumping syndrome, which is annoying, but it's where you have symptoms after eating, and there's an early and a late phase. Early is within 20 to 30 minutes after your meal, and that's because a bunch of carbs dump into your intestine, and you get this hyperosmotic load where fluids shift and you get lightheaded. Whereas 2 to 3 hours after the meal, when you have a bunch of carbs dump into there, you finally get this reactive increase in insulin, and that can make you hypoglycemic. The treatment for both is dietary, small volume meals, less carbs, more protein and fat. You can give octreotide to slow down stomach emptying, and surgery is sort of your last resort. Then there's an afferent limb syndrome, which is where this afferent limb is either too long or it has a stricture, and so you get a buildup of pancreas and bile secretions in that limb, and then they dump into your stomach and you get nauseated and you vomit. The treatment is either to dilate a stricture or to redo this anastomosis with a shorter limb if the limb is too long. Blind loop is similarly a problem with the afferent limb, but this is where there's poor motility and you get bacterial overgrowth. That leads to deconjugation of B12 and you get anemic. And you diagnose this by getting a culture of the fluid in there and it's positive for bacteria. And so you treat it with antibiotics. OR is reserved for refractory, where again, the limb is too long and you need to make it shorter. And then these are pretty quick. Internal hernia. Anytime a gastric bypass patient and they have an SBO on the ABSITE in real life, you should go to the OR to rule out an internal hernia. If you have an obstruction of the afferent limb, this is technically a closed loop setting, so the NG won't decompress, and that also needs OR. Whereas the efferent limb, that's just a regular old SBO, and you manage it like any SBO. Bile reflux happens when bile comes from the afferent limb into the stomach, and so that's generally treated with PPI, cholestyramine, or if you need to, convert it to Roux-en-Y so that the bile dumps into the intestine instead of the stomach. Marginal ulcers happen right at the gastro J, and you treat them just like you would any peptic ulcer disease with a gram patch. They need lifelong PPI. And then you're going to have jejunal intussusception. If it's seen incidentally, you don't need to do anything for it. But if it caused an obstruction, you have to redo the anastomosis. All right, last slide. GI hormones. How are we doing on time? Can I talk about this or should I just have people
Yeah,
look at
you can
it?
go fast.
Okay, so these are the most important hormones they're going to ask you about. The first is cholecystokinin. That comes from the eye cells, kinin eye cells. It's made in the duodenum in response to food coming into the duodenum, and it says, "Hey, gallbladder, I need my bile, so squeeze." And so cholecystokinin squeezes the gallbladder. It also squeezes pancreatic enzymes, and so it's the duodenum sensing food and saying, "Gallbladder, pancreas, help me out." And then there's secretin, which is from S cells, which is easy to remember as well, also from the duodenum that increases secretion of pancreatic enzymes. Less commonly asked about is gastric inhibitory polypeptide or GIP. This comes from K cells. Who made that up? I don't know. I don't have a good one for that. Sorry. But GIP decreases gastric acid secretion and increases insulin. Just try to memorize it, but thankfully they don't ask about it that much. And then there's gastrin, which is it comes from the antrum of the stomach, and that causes release of acid and intrinsic factor, which helps us bind B12. And so that's why they used to do entrectomies to decrease acid secretion. And then somatostatin, it comes from pancreatic D cells, D for down, because somatostatin turns down everything. It's just the inhibitor of the GI tract. VIP, which actually comes from nerves, is vasoactive intestinal peptide, and it causes water secretion and electrolyte secretion. And so that's why VIPomas cause diarrhea. And finally, motilin, which is easy. It just increases small bowel motility and it comes from everywhere. So those are my slides. I have a couple of other ones that we don't have time to go through. So I'm just going to briefly put them up here for like 2 seconds so people can review them later if you want.
Yeah, for those who joined late, this will all be available on YouTube in few days. So you can always go through and pause, go half speed, etc. Dr. Reeves, that was fantastic. Thank you so much. Really helpful. Very broad range of topics that you had to cover. So that was great. Once you're done showing your slides, you can stop share and then we'll go on to Dr. Eisbrew, who will go over a lot of thoracics and trauma.
All right. So we'll get into it here. Learning objectives for these topics are to discuss diagnosis and management of patients with thoracic disease, traumatic injury, and critical illness. Um, just wanted to point out to people on the Zoom call, take a look at the ABSITE content topics. The distribution is not equal among all topics. So, I love thoracic surgery. I'm a thoracic surgery trainee, but it only represents 2% of the ABSITE content, whereas trauma is 6% and critical care is like 14 or 15%. So when you're studying, just keep that in mind. Don't get too in the weeds in some of the topics that are less well represented. Um, Thoracic surgery we'll go through quickly here as it represents just 2%. These are kind of the topics we'll cover. I'm not going to talk about airway tumors, chest wall tumors, lung transplant or heart transplant, cardiac, or, endemic fungi. Sometimes those topics do appear. I think for anatomy for thoracic, other than the esophageal anatomy that Dr. Reeves already covered, the main thing that I've seen is they like to ask the levels of the diaphragm that different structures pass through at. So they have the IVC, at T8, esophageal hiatus at T10, and aortic hiatus at T12. I often have seen the question of where does the thoracic duct enter or cross from the abdomen to the chest, and it goes with the aorta at T12. Um, for lung cancer, this is a topic that is very important for thoracic surgeons, but for the ABSITE, it's really not tested very heavily, and the management is pretty complicated, so I wouldn't spend too much time in your review getting into it, but they do sometimes ask about lung cancer screening. So it's anybody 50 to 80 with a 20-pack year smoking history that's either a current smoker or quit within the last 15 years. There are some other guidelines other than the United States Preventative Services Task Force, but that's the one that appears on ABSITE. For the management, I guess I would say just don't go too into the weeds for lung cancer for ABSITE. Um, they do ask about PFTs though, so they'll tell you that a patient has lung cancer and is going to require a pneumonectomy or a lobectomy, and they'll give you like the PFT data and then ask you if the patient is a candidate for the operation. So the numbers to remember for ABSITE are the ones I have here. a predicted postoperative FEV1 greater than 0.8 liters or 40% of predicted, and greater than 40% of predicted for DLCO. They don't usually ask in the milliliters per minute per millimeter mercury. But if you remember those numbers, the patients can have any thoracic operation that's necessary. And then if it's not clear, there's a big tumor on one side and they're kind of borderline. Sometimes it may ask you what the next step would be, and then it would be a VQ scan to see if the lung is equally contributing to their oxygenation and ventilation. Spontaneous pneumothorax does appear on the ABSITE. This, is a syndrome that classically presents in tall, thin young men. The initial treatment is a chest tube, and many patients will get better with just that. But some do require an operation. That's patients that have a persistent air leak, patients where you can't get the pneumo to go away, basically non-re-expansion of the collapsed lung. High-risk patients, I haven't really seen that, I guess, on the ABSITE. And then patients where they have a recurrence, so maybe it's their second time having a spontaneous pneumothorax. The operation is a VATS blebectomy and pleurodesis. This is usually a mechanical pleurodesis. You take like a Bovie scratch pad and scratch all the surface of the chest wall. Empyema is sometimes tested. So usually this is a peripneumonic effusion that then organizes into an empyema. The image they may show you will look like the CT scan that I have on the slide here, where you see a fluid collection within the chest and some bubbles of gas. The treatment for this is usually a small bore chest tube and then TPA and Dornase. Sometimes they'll test on Light's criteria, which again, you guys probably know from medical school, but if the pleural protein is more than 50% of the serum protein level, if the pleural LDH is more than 0.6 times the serum LDH, or if the pleural LDH is more than 2/3 the upper limit of normal, that would indicate an exudative effusion or an empyema. Indications for surgery for empyema are basically a trapped lung. So if you can't get the lung to re-expand despite tube drainage and TPA Dornase, usually that happens with loculation, or if they're having infection that's not clearing. So, clinical signs. They do sometimes ask about mediastinal masses. The main question is typically what is what's the differential, or which of these could this mass be? And then they'll show you a mass in a different area of the mediastinum. The sort of old terminology is anterior, middle, and posterior. People in thoracic surgery are now really calling those prevascular, visceral, and paravertebral with slightly different definitions of the boundaries, but the point is more or less the same. So for anterior mediastinal masses, these are the four T's that you hear about. So thymoma or thymic carcinoma, terrible lymphoma or lymphoma spectrum tumors, germ cell tumors, which can be seminomas, non-seminomas, or teratomas, and thyroid and parathyroid, either tumors or benign disease. In the middle mediastinum, you typically just have duplication cysts or certain rare cardiac tumors. And then the posterior is almost invariably a neurogenic tumor, which is typically either a benign schwannoma or rarely a malignant nerve sheath tumor. They do like to ask questions about tracheoinnominate fistula. So this usually happens. The scenario they'll give you is somebody did a tracheostomy that might have been have a low entry into the trachea, or maybe they've had some infection at the neck, and then they'll describe a bleeding episode. And there's kind of two scenarios. One is there's like a bleeding and then it stops and the patient's okay. We call that a Herald bleed. So for that patient on the ABSITE, the answer is to do a bronchoscopy and evaluate. And then they may describe a scenario where the patient's having massive hemorrhage. And in that case, you want to do finger compression. So you're basically sticking your finger either through the hole where the tracheostomy was or alongside the tracheostomy, and then compressing the innominate against the sternum until you can get to the OR to do a median sternotomy. Trauma, so that's enough for thoracic. We'll go into trauma. So there's a lot to cover in trauma. We'll try to get through some relevant topics here: head trauma, neck trauma, chest, abdomen, a little bit about blood transfusions. We're not going to have time to go through burns, vascular trauma, and pediatric trauma, but those are things you guys should definitely still review. For neurotrauma, the main thing that they like to test is the GCS score. They really like to go through like giving you a patient scenario and asking you, what is this patient's GCS score? So to review, it's a score 3 through 15. You can get 1 through 4 for eyes, 1 through 5 for verbal, 1 through 6 for motor. So I kind of remember like 4, 5, 6. For eyes, the way I remember it is I just remember 4 is like normal. You can just open your eyes. 1 is they don't do anything. They can't open their eyes. So then you just have to remember the 2 in between. And so to command and to pain are pretty easy to sort of intuit once you know 1 and 4. Verbal, I have sort of a similar strategy. So, 5 is oriented. If you can remember that they're normal and oriented, and 1 is none, you can kind of work your way back and you say, okay, if they're oriented, a little bit less than that would be confused, a little bit less than that still saying words, a little less is saying sounds, and then 1 is not saying anything at all. Motor, this is the one that I think is the hardest to remember for whatever reason, probably because there's 6 different things, but just try to keep in mind again, 6 would be normal. You say move your leg, they move their leg. 1 is they don't do anything. And then if you work your way down, localizes to pain, you pinch their toe and they yell, "Why are you pinching my toe?" and they move it. And 4 is withdraws to pain. You pinch their toe and they sort of pull it back. 3 is flexion, and 2 is extension, and then 1 is none. And so you sum those all up, you get your score. And then just one other thing to remember is if they have less than 8, intubate. So make sure you do an endotracheal tube if they give you an ABSITE question with a GCS of 5, 6, 7, something like that. Neck anatomy is often tested. So this is really for penetrating neck trauma. So that would be anything that violates the platysma. If it doesn't violate the platysma, it doesn't count. This is a little bit confusing in that the zones go up. Most of the time, I think our zones are going down when we talk about these sorts of things. But zone 1 is anything from the clavicles up to the cricoid, or the cricoid down to the clavicles. For any hard signs or an unstable patient, you would go to the OR. And for this zone, you want to do a median sternotomy because the risk of a great vessel injury is significant. If the patient's stable, then you can do a CTA. If there's some great vessel injury, endovascular treatment usually is the way to go. And then you want to evaluate them with a swallow and or EGD and a bronch. Zone 2, which is the cricoid cartilage, the angle of the mandible. This is the easiest area to explore. So your threshold for an operation should generally be a little bit lower for a zone 2 penetrating neck injury. But for these, again, any unstable patient or with hard signs, you want to go to the OR. This would be a lateral neck incision. If they're symptomatic but stable, then you would still take them to the OR for exploration, and then you do an EGD or bronch, EGD and bronch if you don't find an injury but have ongoing suspicion based on what you find in the OR. If they're asymptomatic, you can do a CTA and then a swallow or an EGD and a bronch. Just to review what are hard signs. So shock, active bleeding, an expanding or pulsatile hematoma, airway compromise, subQ emphysema, or a focal neurological deficit. So these things should be pretty obvious that something terrible has happened from the neck injury. You should probably explore it in the operating room. For chest trauma, so this is from the West Trauma Guideline. They have some algorithms that are generally concordant with the correct answer on ABSITE. So for an unstable patient with penetrating chest trauma, basically the first thing you want to do is cavity triage and resuscitate. So after getting your ABCs, you want to do a chest radiograph and a FAST. And what you're trying to sort out basically is, are they at risk for a cardiac injury, or does this seem more like a lung or lateral chest injury? And then you treat accordingly. So if the penetrating injury is in the box, which is basically the line formed by the midclavicular line up to the clavicle and down to the costal margin, these patients are at high risk for a cardiac injury. So they in general should be treated with a sternotomy. Penetrating chest trauma outside of the box, however, can be treated with an anterior lateral thoracotomy. So it's just a little bit different approach based on where the injury is and what the expected findings would be in the operating room. This slide I took from Tom Moo, who made this lecture last year. It's one of the better slides I've seen talking about which incision to make for what injured structure. They'll often ask this on the ABSITE. You heard a little bit about the esophagus already in the last bit, but for basically for any great vessel injury, ascending aorta, innominate artery, left common carotid, you want to do a median sternotomy. If it's a proximal subclavian artery injury, those can be managed through a median sternotomy, but if you get more distal, then you need to do an anterolateral thoracotomy. And obviously a resuscitative thoracotomy is classically an anterolateral thoracotomy. And I think this picture is nice. It shows that those thoracotomy incisions are curving upwards because when you cross the sternum, you want to do that at the 3rd or 4th interspace, which is quite a bit higher than like the inframammary crease where you sometimes see those incisions drawn out on the skin level. So this is again showing kind of like the level for an anterolateral thoracotomy, which would be extended to a clamshell. Sometimes for ABSITE, they'll ask you what level, to make the thoracotomy at. And they might give you like 7th and 4th as an option. You would choose 4th. And again, just a sort of plug here, the clamshell incision really gives you great exposure for both lungs, the heart, mediastinum, great vessels. You can go on bypass. It's a nice incision if you need exposure to things. Um, for stable patients with penetrating chest injury, really the two things that I've seen predominantly tested are chest tube drainage and then injury to other structures. We'll go through that a little bit here. So for hemothorax, you have whiteout chest on a chest radiograph in the trauma bay. The thing to do is put a chest tube, 28 to 32 French is fine. And then the indications for an operation, which can be a VATS or a thoracotomy, depending on the stability of the patient, they probably won't make you choose that on the ABSITE, are the following indications. So if you have immediate drainage of 1.5 liters of blood or more than 200 an hour for 4 hours, I would answer that you do a thoracotomy for the ABSITE. If the drainage within 24 hours is greater than or equal to 1,500 milliliters, I would answer that I would do a thoracotomy for the ABSITE. If you have a retained hemothorax, which is more than 300 cc's of blood, usually on a chest CT and 48 hours after hospital admission, the thing to do is a VATS. They'll sometimes give you options to like put in a pigtail or try TPA or a chest tube. Really, if you've done like 2 days and you still have clot in there, it's like sucking Jello through a straw. It's not going to happen. So you need to take them to the operating room and do a VATS. Um, then the other thing that they sometimes test is question of diaphragm injury and then injury to other mediastinal structures. So for diaphragm injury, the way that they'll present it is they'll give you a chest radiograph like the one on the left here. You'll see some loops of bowel up above the diaphragm. And then they'll ask you like, what's the appropriate incision for this? And so you want to do usually a laparoscopy or laparotomy, particularly if the injury is on the left side, because you need to assess the spleen and the stomach and the colon. Um, and then the classic repair is done with permanent suture. So usually people are doing ethibond, at least in a board type scenario. If you have a penetrating injury with a transmediastinal course, you want to rule out a cardiac injury with an EFAST. You can rule out an airway injury with a bronch, and an esophageal injury again with a swallow or EGD. So those are kind of similar to penetrating neck in the way you look for those types of injuries. For penetrating abdominal trauma, really the first question for ABSITE is, was this a gunshot or a stab wound? If it's a gunshot, the patient should go to the OR and have a laparotomy. If it's a stab wound, then there's several different options, and I think all of them are kind of fair game for the ABSITE. So basically what those entail, and again, this is from the West Trauma Guidelines, is a local wound exploration. So this is something you can do in the trauma bay. Basically, you use retractors to get down to the anterior fascia and determine was it penetrated or not. And if it's not penetrated, then if the patient's okay, you can just send them home. If it is penetrated, then you can either choose one of these other pathways or you can do a diagnostic laparoscopy. And again, this is for stable patients with a stab wound. The other options are to do serial clinical exams or a CT scan. And if you do a CT scan and there's no injury, then most for the ABSITE, I would say observe, although some people do think that you can discharge those patients with a negative CT scan. For blunt abdominal trauma, and I'm not really going through all the ABC stuff because I think people get that kind of hammered in their residency program, but I think it's good to have an idea of what you would do with different organ system injuries. I think this really does show you basically the basics of what you need to know for the ABSITE in terms of evaluating a patient in the trauma bay with a blunt abdominal trauma. So you go through your ALTS, ABCDE secondary survey, and then you determine are they stable or unstable. If they're stable, meaning normal blood pressure, normal heart rate, then you go for a CT scan. If they're unstable, hypotensive, tachycardic, then you do a fast exam and give them resuscitation. And so if they remain unstable on the ABSITE, then you just go to the OR. If you find a splenic injury, you remove the spleen. So the other option is they're stable. If they're stable, you do a CT scan. And if the CT scan shows you a splenic injury, then the question is, well, what do I do with that injury? And basically, if there's no angiographic blush and it's not a grade 5 injury, then you can observe the patient. If there is a blush, or then you go to angiogram and have them embolize the splenic injury. And if it's a grade 5 injury, or if they have other injuries or they've become unstable during all of this, you take them to the operating room for a splenectomy. So that's pretty straightforward. Liver, this is a busy slide. This is also, again, the West Trauma Guideline, but I think the main learning points here are kind of at the bottom. So if a patient's unstable, has a positive FAST, you take them to the OR and you deal with the injury. If they're stable and you get a CT, then it really depends on the grade of injury what you do. So low grade, which is Sorry, I just skipped ahead here a little bit. Low grade, which is 1 and 2, those you can just observe and do non-operative management, and then if they become unwell, then you take them to the operating room or reassess at least. If it's a high grade injury, which is grade 3, 4, or 5, those patients you typically start with angioembolization, assuming they're still stable, and then observe them. And then if they become unstable or the angioembolization fails, they don't see it or they can't fix it, then you take them to the operating room. This little chart here reviews the AAST liver injury scale. I haven't seen a lot of questions where they specifically ask you what is the grade, but I think it's important to just know like what's the cutoff where you need to do something other than observation. So for a liver injury, grade 3, are the ones that you need to embolize or operate on. And so these basically include, hematomas more than 50% of the surface area, bigger than 10 centimeters, a tear greater than 3 centimeters, or a blush. And then things that are less than that in general for ABSITE you can observe. So just to summarize again, all that busy information: unstable, give blood, assess stability, and then either the OR or hybrid room. And then if they're stable, again, like we said, grade 1, 2, you can do non-operative management, 3 through 5, or blush, IR, and then OR. And a retrohepatic IVC injury should always go to the OR even if they're stable. They like to ask about the zones, the retroperitoneal zones for penetrating and blunt injury, and then what the appropriate management is. So zone 1 basically is the middle, which includes the aorta, the IVC, the origins, the renal vessels, duodenum, and pancreas. These injuries need to be explored no matter what. So any zone 1 hematoma needs to be explored, whether it's a blunt or penetrating etiology. Zone 2 hematomas, it depends on the mechanism. So if it's blunt, then you're basically looking for instability or an expanding hematoma, then you need to explore those. If it's a penetrating injury, you need to explore them. And for zone 3, which is the pelvis, typically for a blunt injury, the treatment is a pelvic binder, an X-fix by ortho. Sometimes you can do arterial embolization of the internal iliacs. And then if the patient's failed all of those things, then the answer on ABSITE will be preperitoneal packing. And if they have a penetrating zone 3 injury, then you explore. So for any retroperitoneal hematoma, if the mechanism is penetrating, just explore it for the ABSITE. And then if the mechanism is blunt, then it just depends. So 1, explore; 2, observe; and 3 usually is some kind of pelvic compression treatment modality. They'll often give you a scenario on ABSITE where the patient's already in the operating room and they want you to make a decision about how to best manage some complex injury pattern. And in general, I would have a low threshold for ABSITE to select answers that are consistent with a damage control strategy. So if they're giving you a patient that's having hypothermia, acidosis, or coagulopathy in the operating room, do whatever the minimal thing is to basically temporize bleeding, control spillage, and get that patient out of the operating room for resuscitation. And there are numerous scenarios they can give you, but if you keep that principle in mind, you'll usually get through most of those intraoperative catastrophes. I think this comes up a lot. So this slide, or this little picture that I took in our ICU, is really helpful for me in answering these questions. Basically, just sorting out if they give you a thromboelastograph, they may tell you the patient has a prolonged R time or a long K time or decreased alpha angle, or a small maximum amplitude, and then what you should be doing with that information. So I think it's kind of helpful to just review this and basically say, okay, long R time, is this a clotting factor problem? They need plasma. Long K time or decreased angle, this is basically the time to forming strong clot. It's multifactorial. Usually plasma is the right answer. If they don't give you that as an option, then pick cryo. They probably won't make you pick between those two. And then maximum amplitude, this is final clot strength, but mostly depends on platelets. And so if you have a low MA, give platelets. And then the 30-minute lysis percentage, or LY30, they don't usually ask about on the ABSITE, but you can consider TXA, because that usually is from a fibrinolysis problem. So in our last little bit here, we'll go into critical care. Probably won't get through all of this in our time, but we'll do some important things. So this comes up on the ABSITE almost never in real life, in my experience. They love to ask about the respiratory quotient. So this is the ratio of CO2 produced to oxygen consumed, and it's a marker of whether a patient is overfed, normal, or underfed. So a respiratory quotient greater than 1 means overfeeding, and so your answer on that test question is decrease the carbohydrates. A respiratory quotient of 0.7 to 1 is normal, so you do nothing, continue current feeding. A quotient of 0.7 or less means underfeeding, and so in those patients, the answer is to increase carbohydrates and calories. They also like to ask, what is the respiratory quotient of pure fat, pure protein, and pure carbohydrate? And I don't know, you just have to memorize it. Fat 0.7, protein 0.8, carbohydrate 1. And that, I guess if you can remember carbohydrate is 1, that will also help you answer the ones where there's overfeeding and underfeeding, and you remember to just use carbohydrates to adjust those. They like to ask about refeeding. So when you give nutrition to a chronically malnourished patient, you can give them refeeding syndrome. Basically, what happens is potassium shifts from extracellular to intracellular, and this leads to a critical hypophosphatemia and a bunch of downstream effects. They'll give you lab values that show a low potassium, low magnesium, low phos. They may ask what complications they're at risk for. The most common will be arrhythmias and failure to wean from the ventilator. Usually the treatment is KFOS and just more gentle refeeding. So usually 10 to 15 calories per kilogram per day. This equation itself doesn't really get tested that much, but a lot of the components of it do. And so there's a lot of meat on the bone here. If you understand this, you'll probably get all of the physiology questions right on an ABSITE. So the first part is cardiac output, which if you remember the formula is heart rate times stroke volume. Stroke volume is your end diastolic volume minus your end systolic volume. Sometimes they ask ejection fraction, which is your stroke volume divided by your end diastolic volume. In other words, how much was squeezed out divided by how much was there before the squeezing. The things that go into this are contractility, preload, and afterload. You can affect all of these things. You can do chronotropes for heart rate. That's not really something for the ABSITE, but certainly inotropes for contractility, volume, or blood for preload problems, and vasodilators for afterload if they give you a patient with an MI. They like to ask about the oxygen hemoglobin dissociation curve. I think this is an annoying thing to memorize that everybody has to do for each exam. But I think one thing that helped me remember it is rather than thinking about it as left and right shifts, I thought about it like just as up and down shifts, which is kind of more of a mathematical way of thinking about it. And so I thought, okay, for any PO2, what will be the patient's percent sat based on these, percent saturation of hemoglobin with oxygen based on these local conditions. And the things that are shifted right, which in my mind is more like shifted down, is the skeletal muscle world, and up is like a lung. So the lungs are full of air that makes them cold. In the lungs, you want all the CO2 to get blown off and the oxygen to get stuck to the hemoglobin. And then the acid goes away because you're blowing off your CO2. So the lungs are a high pH, low temperature, low CO2, and those have a much higher percent. You want the oxygen to stick to the blood in your lungs. When you go to the skeletal muscle, you want the oxygen to offload. So it would make sense that the natural conditions in the skeletal muscle, which again are like warmer temperature, more acidotic from lactic acid production, higher CO2 from metabolism, all of those things will make the oxygen come off the hemoglobin so that your skeletal muscle can use it. And so you would have a lower percent sat for the same PO2, dissolved in the blood. So hopefully that helps you get some points there. For hemoglobin, you can transfuse, of course, you guys know that. And then the things to increase oxygenation are supplemental O2, or if they're intubated, going up on the FiO2 or PEEP. Sometimes they ask about oxygen consumption. So this is basically oxygen delivery minus oxygen use. And you can measure this with a central venous saturation. Normal is 75%. Sometimes for ABSITE, they'll give you somebody with 90. You need to know that that's poor extraction, typically like a sepsis picture, or decreased, which means usually either increased extraction or poor delivery. So often somebody with like a cardiogenic shock. This slide I think is also sort of helpful. They'll sometimes give you like Swan-Ganz measurements on the ABSITE and ask you what kind of shock is the patient in. And so just going through the mental exercises thinking, okay, for hypovolemic shock, patients are going to have decreased cardiac output because their preload is poor. They're going to have decreased CVP. They're going to have decreased wedge pressure because again, preload is going to be poor on the left side. And they're going to have increased systemic vascular resistance because the bleeding patients, renin-angiotensin and epinephrine are all going to be jacked up and everything will be clamped down. And then they have a problem with mixed venous saturation from a circulation problem more so than an extraction problem. Distributive like sepsis or anaphylaxis is sort of the opposite. So their cardiac output will be increased. They typically will be normovolemic, so CVP will be decreased or normal. Their wedge will be low because it's a distributive problem, and then their systemic vascular resistance will be down. They typically will have an increased mixed venous sat, and then the way to distinguish, septic from spinal is basically the heart rate. And then for these questions, obstructive and cardiogenic are basically the same. And so you can distinguish obstructive by, they'll tell you like absent breath sounds, distant heart sounds, or they'll give you a echocardiogram with a pericardial effusion. And so if they give you those SWAN readings, you can figure out, okay, this patient has tamponade or a PE or tension pneumo. So that's it for me. Hopefully that was helpful. Thank you all for your attention.
That was awesome. What a whirlwind. That was great. Thank you. And we will finish up with the good Dr. Yates, who will teach us everything we need to know about vascular surgery.
Do my best. I'm going to share my screen. All right, to give you guys a preview. All right. Much like Matt, I think it's important to know how much each component is required to kind of contribute to the ABSITE or to the qualifying exam, depending on what you're studying for. Especially if you're in your chief year, you're probably studying for the ABSITE like you're studying for the QE. And there's actually a pretty significant difference in the weighting of vascular and two tests. It's 4% on the ABSITE, but 7% of the qualifying exam. And I would say that that was actually quite noticeable across the two different tests, taking them in the past year. Here's the content I'm going to go over. Just so you know, some of these slides, if they're highlighted in purple, are more for your edification or clinical improvement, and are really not very tested on the ABSITE. Starting with cerebrovascular disease, which is quite a high yield topic for both ABSITE and QE. Knowing the anatomy and any kind of vascular bed is the first place to start, and will probably get you a significant component of the points on any vascular component of these tests. So going over the anatomy, the anterior arteries of the neck are the carotid arteries. The right side comes off the brachiocephalic trunk and the left is off the aortic arch. It's important to know the first branches because they're frequently tested either clinically or just as literally directly asking you the first branch. On the internal side, it's important to recognize that that's the ophthalmic artery, and that supplies the eye, obviously. The external carotid artery, its first branch is the superior thyroid artery, which we're all familiar with from our endocrine sessions. At the carotid bifurcation sits the carotid bulb or the carotid sinus, which is made up of baroreceptors. And so when you massage the carotid bifurcation during surgery, you often see hemodynamic changes affecting the heart rate and blood pressure during the operation and post-op. Not shown here, but important to know the carotid sheath has the carotid artery, IJ, and vagus nerve sitting in there. And that's often just the question straight up is, what structures are in the carotid sheath. On the backside, far less tested, but sometimes clinically relevant are the vertebral arteries. These are paired arteries that come off the subclavian on either side. They are broken down technically into 4 different levels. From V1 to V4, from central to cranial. They ultimately fuse right and left together into the basilar artery, which supplies the brain, and they control the posterior circulation, which is most relevant for balance. Typically, to maintain appropriate flow to your posterior circulation, you really only need one of these intact. That's especially true when patients have a patent circle of Willis, so the patent connections within the brain between the carotid arteries anteriorly and the vertebral arteries that become the basilar posteriorly. If you do have a patent circle of Willis, most of the time your circle will accommodate for any blockage or stenoses of any individual arteries, particularly if you only have one area of severe blockage. It's unlikely that you have cerebrovascular compromise from any of them. Carotid stenosis is the most highly tested pathology of the cerebrovascular diseases. It's an atherosclerotic narrowing of the carotid arteries, which increases your risk of stroke, not due to low blood flow. It's not the same pathology as coronary angina, but due to plaque dislodgement. And so the symptoms here on the ocular side of things are ipsilateral. So if you have a piece of plaque that breaks off and blocks that first branch off the internal carotid, the ophthalmic artery, that is causing a direct lack of blood flow to that eye. And it's actually the ipsilateral eye that would have the shade coming down, amaurosis fugax, versus every other symptom associated with a carotid should be contralateral. So facial droop or motor sensation loss will all be mediated through the brain and should be the contralateral side from the symptomatic artery. Aphasia and word finding difficulty is usually left-sided finding. For treatment, medical treatment for all these patients, they need to be on a baby aspirin and a high-intensity statin. And their imaging workup should include a carotid duplex to establish the flow through the vessel, and a CTA head and neck to establish the level of the lesion and to determine whether that lesion is more thrombotic or calcific. Often where you get tested is whether or not a patient should undergo carotid endarterectomy, and we've had many studies over the years that help us determine which patients should actually get surgery. The big red findings are kind of what to live by, and below I highlight the various studies and the findings for each of these disease pathologies. But the kind of long and short is that symptomatic patients, meaning people who are having TIAs or have had stroke symptoms with greater than a 50% narrowing, should have a carotid endarterectomy within 2 weeks of presentation. It's both a surgical indication and relatively urgent. On the right, I apologize, I should say asymptomatic. Those patients on the right side should say asymptomatic patients greater than 70% stenosis who have a low perioperative risk and a greater than 5-year life expectancy can also be considered for surgery. This is probably a pretty movable and mobile target, and this may be less tested because there's less and less surgeons across the nation who are excited about doing carotid endarterectomies, except for reimbursement. I will highlight that all these studies are done against medical treatment with just an aspirin alone, so we really don't have any data against statin, and so it's hard to say what the true benefit of surgery over medical management is in these patient populations, and that data is forthcoming. Here, this is our other options for intervening on patients with carotid disease, carotid stenting, and TCAR. Both of them are pretty interesting approaches. Carotid stenting is falling out of favor, and TCAR is becoming increasingly popular, but probably neither of them will be tested on the ABSITE. What is highly tested is how to do a carotid endarterectomy. Many of us will have seen them during our clinical time, but just to review, you make an incision along the anterior sternocleidomastoid, and as you get down through the platysma and into the carotid sheath, you're going to identify the facial vein coming off the IJ, which is crossing over your carotid bifurcation, and you ligate that vein to expose the bifurcation. You'll find small nerves overlying the bifurcation, and most of them are branches of the ansa, but you need to be sure to identify the hypoglossal, which is the larger nerve higher up in the fields. That should be preserved. The order in which you ultimately clamp the vessels is very important and highly tested. Internal, common, external, or ICE. Most important thing is to remember is the internal first. At this point is where you can consider shunting if the patient doesn't have sufficient cerebral blood flow, which can be determined either by transducing stent pressures, by having an awake patient that you monitor their neurostatus, or by using an EEG. Ultimately, you then endarterectomize the intima and media, leaving the adventitia behind, and you make sure that your endpoints of your endarterectomy, especially the distal, look intact. The repair always on the ABSITE and mostly in real life with bovine pericardial patch. And then you'll unclamp in the reverse order, external, common, and then internal to appropriately preserve the blood flow and protect the brain. Next, there's often complications of the carotid that are highly testable. Anytime you see a patient with a carotid having a post-op stroke, you should return to the OR to evaluate for technical error. The rest of these are generally nerve injuries that can be managed conservatively. Hoarseness is likely a vagal clamp injury. Tongue deviation towards the surgical side is a hypoglossal nerve injury. Dysphagia is a glossopharyngeal nerve injury. Asymmetric smile is usually from tugging on the marginal mandibular. And then one thing you need to watch out for in post-op management is cerebral hyperperfusion syndrome. And that can start with a headache and then progress to a seizure. And this is secondary to increase in blood flow that the brain is not ready to compensate for, resulting in cerebral edema. The most important thing here is prevention, so maintaining their blood pressure less than 140 to 160 for the first few days post-op. Sometimes we talk about vascular dizziness. The two etiologies for this are either vertebral basilar disease, so meaning an actual blockage in the vertebral or basilar artery, in which case you would get a workup with a duplex of the cerebrovascular arteries, and you would either see slow or reversed flow in the vertebral arteries, and you get a CTA to evaluate the lesion. You would treat this lesion with a vertebral artery stent. More commonly tested is subclavian steal syndrome. This is when you actually have a more proximal narrowing in the subclavian artery, which is limiting flow to the distal components off the subclavian, which include both the vertebral to your basilar circulation and the axillary and brachial artery. And so what happens is when you start to move your arm and your brain compete for blood flow. And on the duplex, in this case, you'll see reversal of flow in the vertebral artery. Oftentimes we see patients who have dizziness or vertigo. They can also have hand symptoms, numbness or weakness of the hand, and fingertip ulceration. Again, here we treat with typically a subclavian stent. This is just to highlight that a marginal mandibular nerve injury frequently looks like a stroke. It's worth reviewing these images just clinically. It can save a lot of head CTs. We'll move on to thoracic outlet syndromes, which are frequently tested. It's important to know the anatomy, and you're probably familiar with this from doing subclavian lines, but anterior to posterior in the thoracic outlet, you start with actually the clavicle and the subclavius muscle. Generally, those two structures are pretty much overlooked. But in the actual outlet itself, the order of things is subclavian vein, phrenic nerve, anterior scalene, subclavian artery, brachial plexus, middle scalene, And then most posterior to the middle scalene is the long thoracic nerve, also infrequently tested. I tend to remember this by remembering that the order is always vessel, nerve, muscle, vessel, nerve, muscle. And obviously when you're doing a subclavian line, you slide right off the clavicle into the subclavian vein, so that has to be the first structure that you come to. Thoracic outlet syndrome is a compression of new structures that we just highlighted within by the first rib or a cervical rib, and it's usually compressed with repeated overhead use. The most common type is neurogenic, which is numbness or weakness in the hand caused by compression, theoretically, of the brachial plexus. It's a relatively hard thing to diagnose. You generally get neurogenic studies to rule out any other etiology or causes, and the treatment is physical therapy for as long as the day, for as long as you can. Surgery should be a last resort, but it is the most frequent indication for surgical intervention. Venous TOS is the most tested on ABSITE. It's also called Paget von Schroeder or effort-induced thrombosis. You'll have findings of upper extremity swelling, and you'll get a CTA that diagnoses either a subclavian or axillary vein thrombosis. The treatment pathway here is to get rid of the clot first with lysis, put them on anticoagulation for several weeks, and then bring them back for the surgical intervention. Arterial TOS is the least common, but most urgent. It's a thrombosis at the site of compression that can lead to either embolic showering or a post-stenotic aneurysm. The treatment here is an emergent bypass for ischemia. You usually can't just open up the clot because the stenosis aneurysm is significant enough that it can't be repaired. And then if patients are having blue finger syndrome and showering, you do anticoagulate them. The treatment surgically for all of these syndromes for decompression is a first or cervical rib resection. Here's a photo of what a surgical rib looks like in case you haven't seen one before. And that's ultimately the definitive treatment. There are 4 different approaches, all of which are considered clinically relatively equal, except for neurogenic, in which case you need to do a supraclavicular approach. Moving on to thoracic and abdominal aortic disease. I'm going to highlight here the things that are relevant for kind of the general surgery approach. There's a lot more to this component specifically, but these are the things I would focus on. Recognizing the anatomy of the aortic arch and the abdominal aorta is really key, and a lot of your questions will come from here. Most important is to recognize that the left subclavian is the last branch off the aortic arch, and understanding the blood supply from the celiac and the SMA and knowing its implications is a really important component of the abdominal aortic anatomy. We'll start with the aneurysms. The aortic aneurysms are defined by the region of the aorta involved. They're often asymptomatic, but any symptoms that come from compression of the nearby structures. We tend to repair these electively whenever they meet quote unquote size criteria for risk of rupture, which is different by each level of the aortic body. At the ascending and arch and the thoracic aortic aneurysms, I put these in purple because they're rarely tested and tend to be more the realm of cardiac surgery. If greater than 5.5 of the ascending arch, or if the patient has Marfan's, those tend to require open cardiac surgery. And then in the thoracic aorta, this is considered any aneurysm that begins in the thoracic aorta beyond the takeoff of the left subclavian. Those are treated with a TVAR over any open repair for 5.5 centimeters or greater. This is an intervention that has the highest risk of spinal cord ischemia. Thoracoabdominal aneurysms are the purview generally of vascular surgery, but are again pretty complicated and minimally tested on the ABSITE or the QE. The cutoff here, because the intervention is so significant, is an open repair when they're greater than 6 centimeters, unless they have particularly high risk features, in which case we'll intervene at 5.5. This highlights the different types of thoracoabdominal aneurysms, but I've never seen a question on this on the ABSITE or QE. What's highly tested is infrarenal aortic aneurysms, and this is where most of your questions are going to come from. It is also the most common clinically form of disease. The risk factors are atherosclerosis, cigarette smoking, and hypertension. They like to ask about mycotic aneurysms, frequently tested, infrequently seen, but if they do occur, they're caused by either staph or salmonella. We repair them for size cutoffs of 5.5 centimeters in males and greater than 5 in females, or for any growth greater than 1 centimeter a year. Open repair is favored in patients who are younger or have connective tissue disease, and this is with a Dacron or bifurcated graft, tube or bifurcated. And then a lot of questions in these open repair situations come about what to do with the IMA. And so what you need to think about is how much flow you have through that IMA. If it's already occluded, you just reinforce the occlusion and don't think about it. If the patient has excellent back bleeding, that means they have sufficient collateral flow. You don't have to worry about inflow into the IMA, and so you ligate it. Only if there's poor back bleeding do you reimplant this IMA. You should consider if patients have had prior colonic surgery and kind of have a higher priority to reimplant if they've had prior alteration to their vasculature to the colon. Big complications for open repair, AKI, graft infection, which is again with staph epi, and then ischemic colitis. That one is frequently tested. EVAR is becoming more and more relevant for the ABSITE. The questions I usually see are on endoleak, which are listed there on the right. It's a less invasive intervention, but it requires more frequent secondary interventions throughout the lifetime of the patient. And so it's really not favored in the younger patients. They do tend to ask you about anatomic requirements. And so who can get an EVAR anatomically? I think the most relevant thing to know is that you can't have very tortuous or calcified iliacs or femorals. And they will often ask you about the neck, where I think the answer right now on the ABSITE for what kind of neck you need for an EVAR is 1 centimeter. But I think this is probably a pretty unfair question because there's a lot of devices on the market that are changing that paradigm. So I'm hoping that this is not going to be a highly tested area for you guys. Complications to know here: groin axis infection, embolus, and then it's very important to recognize these types of endoleaks. Type 1 endoleak is leaking around the site of the graft, either proximally or distally, where they actually have landing zones at the end of the graft. Type 2 is probably the most tested, is when you have lumbar arteries leaking back into the sac and causing expansion. Type 3 is when you have either a tear in the graft or a leak from different components of the graft sitting within each other and not appropriately overlapping. Type 4 is from graft porosity, almost never clinically seen in graft. Type 5 is we can't figure it out. It's probably an undiagnosed type 2. In this case, it's important to know that type 2 is monitored and types 1 and 3 are intervened upon. Next, we'll move on to aortic dissections. This is the separation in the medial layer of the vascular wall. Risk factors here are hypertension and atherosclerosis, and the most important thing to know is the Stanford classifications, which is the location of the tear. The type A dissections are ascending aorta, and type B is a tear that occurs distal to the left subclavian. There are also DeBakey classifications that also highlight the location and extent of the tear. Those are much less frequently tested. Here, type A, is important to know that it's an open aortic repair for anyone who has a type A aortic dissection because of the risk of the dissection propagating proximally and causing damage to the coronary vessels, which you can see on the left here, and that could cause obviously an urgent heart attack. Type B is generally managed non-operatively with impulse control with beta blockers, unless they have any visceral or limb ischemia. If you do end up forced into intervening here, it's usually a TVAR. Next is mesenteric ischemia, also highly tested. The most important and relevant anatomy for mesenteric ischemia is the SMA. As highlighted earlier, the celiac artery primarily applies the stomach and is less relevant and more collateralized. But if we have trouble with the SMA blood flow, that's when we're starting to talk about mesenteric ischemia. There are 4 types of acute mesenteric ischemia. Embolic is the most common and most commonly tested, usually an embolus from the heart, typically from undiagnosed AFib. Because it's a small clot, it usually lodges just a little bit distal to the SMA origin. Thrombotic disease usually occurs in people who have atherosclerosis at the SMA ostium and actually occludes the ostium itself. These patients frequently have chronic symptoms of postprandial pain before they have an acute presentation. NOMI is a low flow state in critically ill patients who have not enough flow through their SMA, and that's how they end up with ischemia of the gut, and generally a non-operative indication. Similarly, venous thrombosis is a more subacute presentation from mesenteric venous congestion, and it tends to lead to more cramping pain and bloody diarrhea, and again is less and non-operative intervention from a vascular surgery standpoint. In terms of management for acute mesenteric ischemia, it's still a very high risk diagnosis with an over 50% mortality rate. The classic kind of symptom of presentation, no matter kind of which of these etiologies you're talking about, except for perhaps the venous thrombosis, is pain out of proportion to exam. So it's people who are coming in complaining of a lot of pain and their tenderness on their belly and their overall exam is not as impressive as you would expect for how much they're complaining of pain. Work up here is to get a CTA to evaluate the level of occlusion and look for bowel ischemia, and it's often useful to trend a lactate. The management here is every time any kind of concern for mesenteric ischemia arises, regardless of etiology, you should heparinize. Things that should push you to the OR are peritonitis and concern for bowel ischemia. First, you want to actually evaluate the bowel, resect anything that's frankly dead, but anything kind of borderline viable should be left behind. And then get your vascular surgery team involved for evaluation of revascularization if it is one of the thrombotic or embolic etiologies. Here, the options are open thrombectomy, retrograde stent, while you're looking down at the SMA or a bypass. I'm hoping they wouldn't ask you amongst these options, which is better, but somebody with atherosclerotic disease should probably get a thrombectomy, and a retrograde stent is less ideal in someone who has calcific disease. If they do not have peritonitis, it's appropriate to monitor these patients while their NPO is serial abdominal exams. PAD is a big topic in vascular and pretty diverse, but thankfully not as highly tested. It's important to recognize the inflow to the lower extremity. Particularly tested is the branches of the below knee vessels, recognizing that the popliteal branches first into the anterior tubular artery, and then the TP trunk branches into the peroneal, which kind of runs straight down the middle, and the PT, which runs posteriorly and medially. It's important to recognize the lower extremity compartments, both from a vascular standpoint and trauma standpoint. Here, this diagram kind of highlights the important structures in each compartment. The most important things to know are the nerves and the arteries, where they run. The muscles are pretty infrequently tested, except for the superficial posterior compartment. For some reason, they always want you to know that you have to take down the gastroc and the soleus to get into the deep compartment. So you have to take down the superficial posterior to get into the deep compartment. You can review this slide at your leisure. Atherosclerotic PAD is calcific narrowing of the blood vessels supplying the lower extremity. The biggest risk factor is smoking, but also high cholesterol and family history. It's evaluated by an ankle brachial index, which is the ratio of the blood pressure in the upper extremity to the lower extremity, where normal is 0.9 to 1.1. Patients have claudication, which is calf or foot pain with walking, essentially demand ischemia of the lower extremity, with anything less than a 0.9 ABI. Rest pain, meaning calf or foot pain with elevation, is seen at an ABI of less than 0.5. And clinically, it looks like dependent rubor. Their foot gets red and swollen when they put it down. And then tissue loss, ulcers or gangrene is seen below 0.4. Here, the management is divided into those who have claudication versus true rest pain or tissue loss, which is considered a CLTI. Claudication should really probably in the ABSITE not be intervened on surgically. Your answer should be medical management, having the patient quit smoking and get on the statin, and then also be on an exercise or monitored walking program. In real life, we do talk about cilostazol, but that's not something I would answer on the ABSITE. Rest pain or tissue loss, this is where we're talking about surgery. If they have this diagnosis, we should revascularize with them within 1 month. And if infection is present in the setting of tissue loss, you need to debride or do a guillotine amputation to take care of that infection before revascularization. You evaluate the level of lesion with a CTA or an angiogram, and you get vein mapping to look for any kind of available conduit and planning your intervention in these patients. Your operation for peripheral artery disease is determined by the level of the blockage and your conduit that's available. At the aortoiliac level, this is also known as for occlusive disease Leriche syndrome, which is seen in younger patients and manifests as claudication. Here, your primary intervention for a good surgical candidate would be an aortic, femoral, or bifemoral bypass. And in more frail patients, you do an extra-anatomic axillary or bifemoral bypass. In femoral popliteal disease, most recent data suggests that bypass with vein is the ideal intervention over anything endovascular. And that's what I would answer for anything femoral popliteal on the ABSITE. In tibial disease, this really shouldn't be tested on the ABSITE, but you should never use prosthetic graft below the knee. This is really a case-by-case kind of disease process, so I'm hoping it won't come up for you guys. Acute limb ischemia is also highly tested. This is rather than kind of chronic atherosclerotic disease in typical PAD, this is an acute change in blood flow to the lower extremity causing severe ischemia. This is where our 5 Ps come in: pain, pallor, pulselessness, paresthesia, and then the made-up word poikilothermia, which means cold. Causes here is most common, again, is embolus, usually from arrhythmia, but patients with chronic atherosclerosis can also have in situ thrombosis, causing an acute obstruction. Those who have atherosclerosis or PAD are usually less symptomatic because they already have collaterals. Workup here is pretty much the same. You get a pulse exam at all levels to assess for Rutherford's classification, which we'll go into next. And you can either do a CTA if you have the time, or take them straight to a hybrid room and do an on-table angio to assess the level of the lesion. Highly tested here is the Rutherford classification, mostly 1, 2, and 3. 1 is mild disease with signals intact and no deficits. 2 incorporates any motor or sensory deficits and have loss of signals. And 3 is essentially profound and irreversible ischemia with paralysis of the lower extremity, usually the foot. The treatment pathway here is determined by Rutherford's classification. First, you heparinize. That should be sufficient for type 1. Type 2 is heparinization plus surgery, which is either thrombectomy or a bypass. And level 3 is irreversible, so it's an amputation. Here we get back to our lower extremity compartments. These are relevant because you can develop compartment syndrome after revascularization. That's where it most commonly comes up in vascular surgery, but you can certainly develop a compartment syndrome in a crush injury as well. Compartment syndrome really is just swelling constrained by the muscular fascia, such that your intramuscular pressure rises above 20 and prevents venous drainage. Your treatment, as we all know, is a 4-compartment fasciotomy via 2 incisions, a medial and a lateral, each of which should get 2 of the compartments. The biggest thing I ask about here is what structure is at risk, and from your lateral incision, you risk an injury to the superficial peroneal nerve. Dialysis access is highly tested, and so we'll go through this because it's also the single remaining EPA for general surgery residents from the vascular component. It's always good, and even when I go and do access, look at this chart every time to remember my upper extremity arteries and veins. So take some time to look through this and make sure you're aware of kind of where the various bifurcations are for arteries and veins, the upper extremity. The things you need to know are types of access. The first is a non-tunneled HD catheter, usually in the IJ or the femoral vein. This is for inpatients only. If they need a short-term HD in the outpatient, usually that's a tunneled HD line. The ideal long-term dialysis option is a fistula, as we all know. This is a direct anastomosis between an artery and vein, such that the vein becomes dilated and is an accessible circuit for dialysis. Fistulas that are ready for use are determined by the rule of 6s. It takes about 6 weeks to mature. It needs to be 6 millimeters or less and 6 centimeters long with 600 cc's of flow. Just remember 6. A graft is a prosthetic connection between an artery and vein. The benefit is that it can be used much more rapidly, but has a higher risk of infection. These are planning dialysis access, more relevant clinically in terms of getting these consults. But things you should be asking about are the status of the patient's kidney function, whether they've had prior central venous stenosis from central lines or ports. We should be getting for each of these patients an upper extremity arterial and venous duplex to assess their anatomy and determine what level of access could be utilized. And then knowing their dominant hand is always helpful. When you're planning for surgery, and this does come up in the ABSITE, asking you which access would be the best, you would always want to choose a fistula over a graft for anyone who has a non-urgent indication, and you start distally and work your way proximally, with the most ideal fistula being a semino or a radiocephalic. If you do snuff box fistulas at your institution, I would not answer that on any standardized test. Dialysis access complications are frequently tested. The most common is a failure to mature. So fistulas fail to mature for a lot of reasons, the most common being venous outflow stenosis. That often is treated by balloon angioplasty. Other indications or other reasons for failure to mature include subclavian artery stenosis, so lack of inflow, or competing flow from side branches, which is an indication for ligation. Once the fistula is matured, you can have bleeding during HD, which is usually from central venous stenosis causing venous hypertension on the back end of the fistula. This is treated with a fistulogram and a balloon angioplasty. If you have any patient on the ABSITE or QE that has skin breakdown over their fistula or graft with bleeding, they're trying to lead you towards a surgical intervention to either revise or excise the graft or fistula. I would answer nothing else on the ABSITE. And then any patient who has high flow, which is a pretty infrequently tested question, the treatment would be a fistulogram with a banding. The most kind of commonly tested complications of dialysis access are these more ischemic etiologies. The most common one that most people are familiar with is dialysis access associated steal syndrome, which is the bottom one here. This usually is a slower onset presentation of soft tissue and muscle ischemia that has progressive pain, hand weakness, and sometimes fingertip ulceration. In these patients, you'll get a clue that they have either diminished or absent radial pulse or signal. And then that pulse or signal should augment when you actually occlude or put pressure on the fistula. Here, the treatment is either access ligation or, becoming more testable, there are preservation operations, which I'll have another slide for, called the drill or the Rudy, that reduce the flow through the fistula and increase the flow through the native artery without completely compromising the fistula. However, they may try to lead you into dialysis access steal syndrome when it's really ischemic monomelic neuropathy. This is an incredibly rare disease process. I've seen it once, but it's ischemia of truly just the nerves of the hand without ischemia of the soft tissue or muscle. This is usually a patient who presents with immediate pain or paresthesia waking up after their dialysis access creation or as soon as the block wears off without any evidence of other tissue ischemia, so their pulses should be intact. Here, your only option is to ligate your access. For those who want to review, these are diagrams of the fistula preserving surgeries. I think they're probably borderline testable at this point. Last but not least, I'll go through it fast, Rach. I know we're almost done. Venous disease is actually coming up more and more. It's important to know the difference between superficial and deep veins of the upper and lower extremities. These diagrams here highlight in different colors which ones are considered superficial and deep. Importantly, in the lower extremity, anything on the saphenous, lesser or greater saphenous distribution is considered superficial. DVTs Frequently, they'll still ask you about Virchow's triad. So just remember stasis, hypercoagulability, and intimal damage as the promoting factors for DVT. The symptoms we all know, swelling, pain, and tightness. And our workup we're all pretty familiar with is a venous duplex. In rare cases, if you're worried about underlying hypercoagulability, checking those labs would be appropriate. Treatment here, if this is a line-associated DVT, we do recommend removing the line if possible. However, if it is necessary, we would not recommend removing the line to replace it elsewhere, rather just treating through the line in place. You should start with anticoagulation for any patient who can tolerate it with a heparin drip, and then transition to a DOAC or warfarin, something oral for a provoked DVT for 3 months. Or for an quote-unquote unprovoked DVT, anywhere from 6 months to an indefinite anticoagulation duration. That's pretty debated, so it shouldn't be tested. Rarely should you be using lysis. The only times when you would be administering TPA in a DVT setting is for either very large symptomatic upper extremity DVTs, which I've never seen tested on any of the ABSITEs or QEs, but occasionally they will ask you about phlegmasia, and I'll go over that. Patients who cannot get anticoagulation should have an IVC filter, but they should also have a plan for removal. Phlegmasia is when you have a sufficiently large deep venous obstruction, either iliocaval or central thoracic, that you obstruct the outflow from your actual lower extremity or upper extremity. It starts as phlegmasia alba dolens. This is where you're truly obstructed in the deep superficial veins that go to the leg, but you have maintained superficial venous dermal collaterals. So the leg will look very swollen. They'll have pain and it will be white, but it will blanch. This progresses then to phlegmasia ceruleus dolens, which has gotten so severe that now even the dermal collaterals are blocked off. And so you have massive swelling, blue discoloration, and no blanching because the venous pooling in the lower extremity or upper extremity less commonly. This is the precursor to venous gangrene, and this is an urgent indication for lysis. This I wanted to get to because surprisingly, this was highly tested on the QE this past year, and I did a bunch of practice questions about venous reflux. Here, your workup for a patient with venous reflux is a standing venous duplex, and you want to see 1 second or longer in contiguous segments of the greater saphenous vein of reflux. You also need to rule out concomitant arterial disease because we should not be treating people who have arterial disease for venous reflux. So that needs to be addressed first. The treatment here is ablative therapies, either thermal or laser ablation, and you access the GSV towards the ankle, and you traverse up with your catheter until you're 2 centimeters away from the SFJ. Oddly tested, again, very frequently, are endovenous heat-induced thrombosis events. There's a whole pathway here for what to do, and this is the current guidelines for how to manage what they call EHIT. And based on how significant the clot is and how much it actually propagates into the femoral vein. If it truly does propagate and become a femoral vein obstruction, you treat as a DVT, and anything less than 50%, you're really just surveilling with duplexes. A patient who has about 50% occlusion of the femoral vein is kind of borderline for any prophylaxis or antiplatelet therapy. But the things that are tested are these frequent weekly duplexes for patients who have any kind of quote unquote EHIT or secondary thrombosis after an ablation. I'll just end with a couple of things here. Venous potpourri, you should review FMD and May-Turner syndrome, just because those are the oddballs that come up frequently. I'll leave this slide here for those who want to review. And then I had a few realistic study recommendations, but mostly know that if you can't follow all the guidelines to be reading 20 minutes a day because you have a real life, you're going to be fine. All of it will come out in the end because you're being well trained clinically as you work.
Amazing. That was great. Thank you again to Dr. Reeves and Dr. Eisberg and Dr. Yates for this awesome review. And just a reminder to register for the January Part 2 session, which will have different topics so that you can ace your ABSITE this year. Thank you again to SSAT for putting this on, and please feel free to reach out via social media with any questions. Awesome. Everyone have a great night and happy holidays.